today I've got this incredible guest joining me in our booth, Jan Norman. She's from Olympia, Washington. She's been a diabetes educator for a few years.
Few hundred.
She's past president of the American Association of Diabetes Educators. And welcome aboard. I wanted to ask you what you've been doing as of late.
Well, Scott, I work for the Department of Health. And in my job with the Department of Health, I manage the chronic disease unit. So I have many different diseases that I administer, diabetes being one, heart disease and stroke, asthma, nutrition and physical activity. So a combination of the risk factors and the diseases. I've been doing that for about 20 years, almost 20 years.
For the Department of Health?
Uh-huh, right.
Terrific. And what's your involvement with the AADE?
Well, during the course of working in public health, which has got a real invested interest in diabetes, I became president of AADE, and I was also president of the certification board for a while, too. Mm-hmm. So AADE has members in lots of different walks of life, not just direct patient care. Public health doesn't do direct patient care. It does kind of the wraparound service around patient care to keep the fragile populations from falling through the cracks to the best of our ability.
So you don't see patients individually, but you try to study them and figure out what
Right.
the public health should be, or what actions. So you have any ideas
Sure.
how to fix diabetes care?
Yeah, well actually, one of the things we do is we measure the impact of diabetes upon the health of our society, from the number of people with it that are being diagnosed with it, that are being hospitalized, the people that are dying, the people that are through their own telephone survey say, I'm doing this, and this to take care of myself. So that's the epidemiology side of the work. And on the other side of the work, what we're trying to do is raise public awareness that diabetes is serious, mm-hmm. and that it can be controlled, and what you can do to control it, but not by doing direct patient care,
right.
More through awareness campaigning. And then another very important piece of work we're doing is trying to change how the healthcare delivery system works. So we're teaching physicians how to do population-based management of people with chronic disease, diabetes being one of them. So that those things that we know we all need to do, like get our eyes examined and feet checked and microalbumin evaluated and blood pressure should be under 130/80, that those things aren't falling through the cracks. Because the way in which the doctor now sees patients is driven by the patient's acute need to see the doctor, not on the doctor's need to see the chronic patient to monitor their disease.
That's significant. We're working on writing up, I'm calling it maybe a Bill of Rights, but it tells the patient, this is everything you mm-hmm. deserve. You
right.
need, you deserve,
right.
You should be asking
Absolutely.
for. And it seems like there should already be something like that.
You'd think so. You'd think so. But
I know the ADA has the standard of care, mm-hmm. but it's like many, many pages. It's not something you can hand out to a patient.
And it's not patient friendly.
Isn't the AAD has some 7?
It has the 7 behaviors.
Oh, 7 behaviors.
And what that is for the diabetes educator to make sure that they cover those 7 behaviors. But I think your point of bringing it from the consumer side is real important, because we don't have a lot of consumer demand around diabetes. And until we do, that's a real piece of the puzzle that's missing. We have right now purchasers waking up that they're paying way too much for how healthcare is costing them against their bottom line. And we're getting health insurance companies saying that we're not necessarily getting the best product we'd like for the money that we're paying mm-hmm. the physicians. And we're getting the physicians waking up saying, I'm being demanded, a lot's being demanded of me to take care of people in this little 15-minute window. But we don't have the patients saying, I want this to be done to take care of me.
Would that be great, like a card or something that mm-hmm. we could give to everyone, so whether they're uninsured, I mean, that's another huge problem, yeah. Whether they're insured, they go, you know what, as a person with diabetes, Scott King tells me I should really be getting Absolutely. All this stuff.
Mm-hmm. We've done those little wallet cards before in public health.
Yeah.
Printed thousands and thousands of them. But we have, I think there hasn't been a great penetration of how to use them.
Yeah.
They're used with a patient going to their regular doctor and filling in their numbers, but the number of people that really use it to drive their care are very small.
We're also, we've had a couple of great articles about hospital care. Mm-hmm. And on our website, people can print sort of a checklist of when you go into the hospital,
Uh-huh.
You know, because often
Oh, you're
the
just-
nurse may not even know how to treat diabetes, and
Absolutely.
they take your meter away and they bring you big loaded carbohydrate meals.
Right.
And
And you really lose control
Yeah.
when you want to maintain control.
Yeah.
Frankly, hospital care is a very scary thing.
is that under
Yeah,
your purview
yeah.
of public health?
Not personally, no. That's not an area that I get into. But if I had a loved one going in the hospital, I'd want to be with them.
So we had an article about the contrast dyes they use for angiograms, and some of them can send people into kidney failure,
Yep.
and that's why you need to request. There's other dyes that aren't as harsh on your kidneys.
Ah,
So a person with diabetes, if they're aware of that, they can prevent problems.
uh-huh. Sure. I mean, there's a lot of different things that people that don't go in the hospital very often have no idea
Right.
that they're going to be forced into a system that is not anything like the system that they use to maintain their control. And
Yeah.
they end up not in very good control while they're there.
My other dream is so we unite all people with diabetes under the same standards of care,
Right.
and ideally that could be around the globe, because what you need in Ethiopia is really no different than what you need in California, though there are problems of finances. But then it'd be great to have a healthcare plan. A lot of healthcare plans now are cutting back on the education, but still paying for the amputations and all the horrible things at the end. And it seems like we need a healthcare plan that
Up front.
takes patients by the hand, even
Uh-huh.
longer than a 5-minute doctor appointment or even
Right.
15, and makes them a partner in healthcare.
Yeah, and that's some of the work that we're actually doing in the state of Washington to teach providers how to do population-based management. Because if they're held accountable for all their patients with diabetes, not just the one that comes in the door and says, well, I've got bronchitis now, treat
Yeah.
me for bronchitis.
Yeah.
Meanwhile, their eyes haven't been checked and their feet haven't been checked for years. They need to be responsible for those population-based measures. The patient doesn't know what those are. The doctor doesn't remember them in that 15-minute window. We need prompters to help them remember those things. These are little tools because our system's not set up to care for chronic disease. It's set up to care for acute disease.
Right. That's such a good example. That how can the doctor, well, big companies like Kaiser do that.
They do.
They send me a letter, you need to come in.
Uh-huh.
You need to come in and go to the lab,
Right.
So,
And managed care, old managed care, which Kaiser is, Group Health Cooperative of Puget Sound is old managed care. They're smart. They know those people are going to stay with them for a long time because they know them.
Right.
And so they're not going to go away when 20 years down the road their diabetes might be manifesting complications. So I better take care of them up front.
that's what they used to tell us, the plans wouldn't pay for that because you would just switch plans.
Every 18 months, right.
And the newest thing is there's so many uninsured, they don't get insurance until they turn 65
Yeah.
when they're on Medicare. And the new
Uh-huh.
study shows that the ones that were uninsured are far less healthy because it's like an old
Oh, yeah.
broken down car.
Yeah.
If they can get it across the finish line, then you get free insurance. But if you pass away, the government saves money. They don't.
Yeah.
It's crazy.
It is.
It's crazy that we have this setup.
We have a perverse system that's not aligned for quality at all. It's not
It's-
aligned for quality.
No.
And we as diabetes educators have seen that for a long time. It's the reason why many of the education centers, which are not self-sustaining by cost, are able to stay. They're not able to stay afloat.
Yeah.
We don't bring in large enough revenue because the reimbursement's so small for this service that we provide.
Right, and they don't see that this education may be preventing something really, really expensive. Well, it definitely is. Is they're looking like at the end of the quarter or something.
Or the
For
end
cost
of,
savings.
Or the end of the 18 months before the patient switches to another healthcare
Yeah.
company. But managed care doesn't necessarily have that happen. And that's why I see them doing really managed care as opposed to fee-for-service, which is really unmanaged care.
Yeah. Well, Jan, this is great. You came over to talk to us.
Thank you, Scott.
Let's keep the dialogue going, and
Appreciate it.
totally think it's great what you're doing.
Thank you very much.
So
Good to
you're
see you
there.
again.
Good to see you again.